Hello everyone, I'm Dr.Myat. Today I would like to make a presentation about the bracket placement in fixed orthodontic treatment. So my channel has both English and Burmese content. So for Burmese content, I mostly make Burmese content for the patients, for the dental education and orthodontic knowledge in Burmese language. But for the English language, I use it mostly for the presentations for undergraduate students or dentists who are interested in orthodontic treatments. So these will be maybe 15 or 20 minutes presentations. So today's presentations is about the bracket placement. So I'll make it as simple as possible. So with the advent of the straight wire appliance, the vertical positions of bracket gain more importance. So whether you put it more gingerly or more occlusally, it can have a major impact on the tooth movement. So since the morphology of the tooth line is not uniform throughout the surface, so there's a curvature on the facial surface, so it's not like a flat surface on the teeth. So if your bracket is slightly off mesial or distal, there can be rotation of the teeth. So that is why we need to put the brackets exactly or maybe at the precise location of the individual teeth. So we need to be well aware of the vertical positions of the brackets, and it can have a variable impacts on the tooth movement. So mostly in my orthodontic training, we have to learn about the Alexander disciplines and Alexander guidelines, MBD guidelines, Rod guidelines, and also in later stages we have to learn about the Damon system and its bracket positioning. So I will try to put most of those guidelines in this short presentation. If you have any extra questions, you can ask in the comment sections and I'll answer it. So for the Alexander guideline, Alexander advocated that individual bracket positioning for each patient for the best result. So it's like an individualized bracket positioning system. So it's not based on like a cookie cutter recipe. So according to Alexander guidelines, the premolar crown is the most variable in the entire arch. So he considered it as an X as a reference. So you can see the graph at the right side. For the first premolar, there's an X here. So you have to measure the height of the premolar, and the position of the other brackets can also be measured upon the premolar's reference height. So you can place individually on different people. So it's not like the same position like 4.5, 5.5, 3.5 millimeter for all persons. So this is what Alexander proposed. And what about the limitations of the Alexander guidelines? So this type of bracket placements help level the incisors and give a good anterior aesthetic, but taking the premolar as a guidance, the clinicians neglecting the clinical crown variables in all the other teeth. So it's like basically focusing sacrificing all the aesthetic perspective mainly on one premolar teeth. So it's not like a really dependable guidelines. So because we have to measure all the incisor and all the social 6, so just by social 6 I means all the anterior teeth. So we need to take considerations of the anterior teeth as well. So what about in other cases, like for the second stage, what if the patient has lost his premolars to curious reasons or any other pathological reasons? And the next thing about the limitations of Alexander guideline is that wire bending is usually required at the end of the treatment for occlusal settling. So for the orthodontics who are trying straight wire orthodontics, wire bending could be a difficult issue for them. So there could be limitations. And the next positioning system is MBT bracket positioning system, which is proposed by McGollin, Bennett, and Traversy, three very knowledgeable professors So let me introduce about these professors. So Dr. Hugo Travassi received his dental degree in 1974 in Linz College of Dentistry in the state of Sao Paulo, Brazil. He is also the faculty member of the University of Odontology and Dentistry in Presidente Prudente, and unfortunately, he has laid to rest in July 3rd of 2021. Rest in peace. And another professor is Dr. Richard McGollin. He finished his orthodontic training at the University of Southern California in 1976. He is also the associate professor at the Department of Orthodontics at the University of Southern California. And the last professor is Dr. John Bennett. He finished his orthodontic training at Eastman Dental Institute in London, England in 1972. He is a part-time clinical instructor at the postgraduate orthodontic program at the Bristol University in England. So, what about their bracket positioning system? So they measure the clinical crown height of the fully erected teeth on the upper and lower study case by the vernier calipers and measuring rulers. And to obtain the middle of the clinical crown, divide the measure height of each crown into the half and round the value to the nearest of 0.5. So for example, if your total crown height is like maybe 9 millimeter, so we have to divide it by 2, so the result is 4.5 millimeter. So if 4.5 millimeter, it's okay. If we get a result of like 4.7 or 4.8, we have to round the number off to like 5 millimeter, or if it's 4.2, we have to round off into like 4.0, or nearest, or 4.5 nearest, we have to round off the nearest number. And okay, for example, if the crown height is like 10.75, the half of the crown will be 5.4 millimeter, and rounding off the number to the nearest will be 5.5 millimeter. For it's like for MBT bracket positioning system, it's mostly like a cookie cutter recipe. For like, if you look at the diagram, you can see that average values of the bracket positioning in adults is like, for central incisors, it's mostly 5 millimeter, for the laterals 4.5, for the canines 5 millimeter, and the premolars 4.5 and 4 millimeter, and for the first molar it's 3 millimeter, and for second molar it's a little bit shorter, it's 2 millimeter. Okay, for the and for the lower it's for 4 millimeter for the central and lateral incisors, both are at the same level, and for the canine 4.5 millimeter, and for the first premolar 4 millimeter, and second premolar is a little bit it's about 0.5 millimeter shorter than the first premolar, and for the first and second molar it's the same, 2.5 millimeter. But for the children it's a little bit like it's 0.5 millimeter less than the adult bracket positioning system if you compare the both charts. Okay, so we'll continue to the next slides. So if we are placing the brackets on the incisors, we should try to get the mesiodistal center or the facial axis of the clinical crown, so that we can get the ideal bracket ideal placement location, so that we can get the best result. So the bracket should be mesiodistally ideally centered at the maxillary and the mandibular incisor. So how can we track these? So the middle developmental ridge of these teeth is also present at the mesiodistal center. So by that we can put the brackets on the mid developmental ridge, so that we can put the brackets at the center of the incisors. So it's not really difficult. You can draw imaginary line of the incisor. If the incisor is tipped or rotated, we have to draw the line as if the teeth is rotated or tipped or angulated. So we cannot place like a straight bracket on the tip teeth. We have to place the bracket also tip along with the tip or rotated teeth. So for the canines, Placing the brackets at the mesiodistal center of the canines will result in the contact point error and slight rotation of the teeth because the mid-developmental ridge of the upper and lower canines lies slightly mesial to the mesiodistal center of the teeth. So basically we have to place a little bit on the mesial side of the canines when we're placing on the lower canines. So bracket is placed slightly off center and towards the mesial in case of the canine bracket positioning. You can also look in the diagram on the right side. And what about the premolars bracket positioning system? For the mandibular premolars, rod is like it's a bracket. He introduced different types of bracket system with the variable tips and tops. So Rod proposed that the premolar bracket should be placed at the area of maximum convexity, the most rounded portion of the tooth, which is usually the mesiodistal center of the tooth, and the middle developmental ridge also lie in this area. So it's basically same concept as the incisors at this point. Sometimes the area of the maximum convexity lies slightly mesial to the mesiodistal center, but the degree of mesial deviation is less than that of the canine. So you can safely put the brackets in the mesiodistal center. You don't need to center off to the mesial. You can just place at the center when you're placing brackets on the premolars. So the difference between bracket placement on premolars and anterior teeth is the presence of the lingual cups, which must be taken into consideration. It is very important while placing the brackets. In mandibular premolars, the buccal and lingual cups lie at the same level in the mesiodistal perspective. If you are viewing at the occlusal view, both the buccal and lingual cups are on the same level in the tangent line. So we have to place the brackets. So the last part, if when placing the lower premolar brackets, the scribe line of the bracket should coincide with the line connecting the buccal and lingual cups. So you can see this picture. So the bracket is placed on the tangent line, which is passing through the lingual and buccal cusp tips of the premolars, so that we can get the mesiodistal center of the clinical crown of the premolars. So this is very important when placing the premolar brackets. So how about the maxillary premolars? The bracket placement on the maxillary premolars is different from the mandibular premolar, as maxillary premolar should have slightly rotated position at the end of the treatment. So according to the Andrew Siski of normal occlusions, the buccal cups of the upper premolar should have a cusp embrasure relationship with the lower premolars, while the lingual cups have a cusp fossa relationship with the lower premolars in class 1 and class 2 molar occlusion, so that the upper and lower teeth have a very good interdigitation. So if the buccal and lingual cups are in one line in the mesiodistal perspective, then both the buccal and lingual cups will have a cusp embrasure relationship with the lower dentition. So such a relation is not acceptable. Okay, so these facts are about this picture, about the cusp and fossa relationship of the upper premolars and lower premolars, and the cuspal and the fossa relationship of the upper premolars to the lower embrasures. Okay, so we'll go to the next slide. So how about the buccal tubes we place on the first molars? The tube should be bonded adjacent to the buccal groove. In the class 1 molar relationship, the distal buccal half of the crown is slightly palatal to the mesiobulbar cups. So to compensate for this, tubes of the maxillary molars are manufactured with a 10-degree distal offset. So it's not like a straight buccal tube. It's a little bit, if you are looking at if you turn the buccal tube like this, it's like there's a 10-degree offset. 10-degree offset in the buccal tube to prevent the molar from rotating mesio-palatally. The tube makes an angle of 10 degrees with its base. When such a tube is aligned, the distal half will be more inward or palatally compared to the mesial half. The mesial opening of the tube should lie below the mesio-buccal cup. This is a very important point in this slide. The mesial opening of the tube, the orifice of the buccal tube, should lie below the mesio-buccal cups. The vertical position of the tube can be measured from the occlusal edge of the molar band to its slot, or if tubes are used instead of bands, the slot of the tube should lie 2 to 2.5 below the molar marginal ridge line. So, how about the mandibular first molar? The slot of the mandibular first molar band should be positioned onto the mesio-buccal groove of the tooth. The buccal aspect of the band should be parallel with the buccal cups, both the orifice of the bands. No offset is incorporated in the mandibular molars, unlike the maxillary first molars. In normal occlusion, the plane of the bracket tube is parallel to the bracket base. There is no 10-degree offset and to the facial plane of the crown. And when we put the molar buccal tubes on the mandibular second molars, the mandibular second molar also have a prominent buccal groove but not a distal buccal groove. The mandibular second molar should have a 10-degree offset. The maxillary second molar should have a 10-degree offset, so that is mesio-buccal cups occludes properly in the buccal groove of the mandibular second molar. So what are the consequences of poor bracket positioning? So first we can get like rotational discrepancy. So horizontal bracket positioning error can result in the rotational discrepancy where the tooth is rotated from its ideal position. So basically, which means it's if you're placing the brackets in the two distal or two mesial perspective, the teeth will be rotated. So this is called the rotational discrepancy caused by the horizontal bracket positioning error. It's often occur in the lower canines and lateral incisor region. For example, if the bracket is placed too far distally on the lower canine, it will cause the canine to rotate distally. So it's basic science. So it's obvious if we have to put exactly on the ideal positioning. So failure to see the bracket completely on the teeth can also have unwanted rotational movement. So basically, when you place the bracket, we have to press with a gentle pressure. So if we don't press it, there will be like excess cement on different parts of the bracket, which makes the bracket not equal on the surface of the teeth. So the teeth becomes rotated because the cement on the base of the bracket are not equal. They are a lot on one side, there's little on other side. So there's no equal cement under the base of the bracket, so the teeth will be rotated. Even though you're placing the brackets in the ideal positioning, if there is a cement discrepancy under the base of the bracket, if you don't seat the bracket properly or remove the excess cement, the teeth will rotate. So what about the angulation issues? If a bracket is not positioning parallel to the long axis of the tooth, it can cause angulation discrepancy and associated rotational discrepancy. Incorrect crown angulation can lead to residual spacing within the arch and prevent the achievement of ideal anterior and posterior occlusion. An angulation error can also lead to incorrect crown positioning in the mesiodistal plane relative to the root. So we don't get a proper root parallelism. When brackets are not placed according to the long axis of the tooth, this can result in increase or decrease of the built-in tip. So there will be no or very little built-in tip. Over-angulating teeth can disturb the embrasures and connectors between the teeth, potentially causing black triangles. Under-angulating teeth can result in spaces that are difficult to close. When a bracket is placed with the intention of overcorrecting a tooth positioning, it can cause the tooth to be positioning too far in the overcorrected directions. So it's very easy. So what about vertical discrepancy? We already talked about the horizontal discrepancy. So vertical bracket positioning errors can lead to the third order tooth errors, such as incorrect torque. Even small vertical errors up to 1 mm can result in 10-degree changes in inclination. So when you're placing the brackets, not ideally, if it's up is more gingivally or more occlusally, there will be changes in the torque values of the individual teeth. So placing brackets too incisively on the lateral incisor can cause intrusion to an increased vertical step between the incisor edge of the adjacent teeth. So placing the bracket too occlusally on the premolar can cause intrusion of the teeth, leading to the marginal ridge discrepancy and poor buccal occlusion with the lower premolars. If a molar tube or band is placed too gingivally, it can cause extrusion of the teeth, leading to a marginal ridge discrepancy and poor buccal occlusion. It can also lead to a lingual crown inclination. Vertical positioning errors can manifest in the buccal segment, such as when the premolar brackets are placed too occlusally, causing a slight intrusion of these teeth relative to the adjacent teeth. This is common in young patients where premolars are not fully developed. So, occlusal and interproximal issues. Poor bracket placement can lead to the failure to achieve ideal dynamic occlusal relationships, incomplete interdigitation of the occlusion due to the vertical positioning errors in the bracket. Incorrect bracket placement can cause marginal ridge discrepancy and occlusal interference. If the teeth are not properly aligned, this can result in the poor contact points and the improper relation between the cups and embrasure of the adjacent teeth. So what about the torque issues? Vertical positioning errors can affect the torque of the teeth. Like I said before, if it is placed too gingivally or too incisively, the torque changes. If a bracket is not placed at the center of the clinical crown, FACC, the torque will be expressed differently due to the morphology of the tooth surface. Brackets with the torque built into the face or slot of the bracket can cause a vertical bracket positioning errors. If brackets are placed too gingivally, this can result in the loss of control of the teeth, particularly with the light round wires. So other issues that causes with the bracket placement are the bracket positioning errors are also common cause of variation in the tooth positioning during fixed appliance treatment. Undiagnosed tooth size discrepancy and variations in the underlying skeletal patterns can also affect tooth positioning. If a bracket is poorly positioning, it is usually more efficient to rebond the bracket. So don't be lazy to take off the bracket and rebond, and then to place the compensating bands in the arch, or to place the compensating bands in the arch. If you don't want to rebond the bracket, you have to do the wire bending. Bracket positioning error can increase the need for the complex wire bending during finishing stages of the treatment and extend the treatment time. Poor axial positioning of the bracket can cause root approximation issues. Sometimes it is so many errors. The roots of the teeth can contact one another and cause very problematic situations. If the brackets are not placed correctly, there is an increased risk of adjacent root approximation, like I said. Incorrect placement of bracket can result in the expression of more or less dip than it is built into the bracket, which may increase the space requirement of the arch. Poor axial bracket positioning can result in the poor proportions of the connectors and embrasures. Errors in the bracket placement can lead to the need for complex wire bending and possibly extension of the treatment time. Okay, so the consequences of the incorrect bracket placement for specific teeth. For maxillary central incisor, if the bracket is not positioning parallel to the long exit teeth, it can cause angulation and rotational discrepancy. And for the maxillary lateral incisor, if the bracket is placed too incisively, it can cause intrusion and increase the vertical step between the incisor edge of the adjacent teeth. For the maxillary canines, horizontal positioning error of the bracket can cause rotational discrepancy. And for the maxillary premolars, if a bracket is placed too occlusally, it can cause intrusion of the teeth and result in a marginal ridge discrepancy between the adjacent teeth and poor buccal occlusion interdigitation. Mandibular first molar, if the molar tube or band is placed too gingivally, it can cause extrusion of the teeth, leading to the marginal ridge discrepancy and poor buccal occlusion interdigitation, and also to a lingual crown inclination. So this is the end of my presentation about the bracket placement. So if you have any questions or concerns about the presentation, you can ask in the comment section below, and I'll answer it when I see your questions. Thank you very much.